Hello and welcome to this mini-gem brought to you by AMY, the Association for Elderly Medicine Education. My name is James Fisher, and in this mini-gem I'm going to tell you about what to do when you think your patient might have Parkinson's disease. Here's the learning outcomes for this mini-gem. First of all, number one, understand what Parkinsonism is. Number two, recognise a common differential for someone who's got Parkinsonian features. And number three, what are we going to do when we suspect this condition? So what is Parkinsonism? Well, Parkinsonism is really just the presence of Parkinsonian symptoms, and these are shown here on the left in the boxes. Yeah, in yellow is bradykinesia, slowness of initiation of voluntary movement, and that's really the hallmark. The other two, rigidity and tremor, are supportive of a diagnosis, but bradykinesia is really what it's all about. Parkinsonism is basically just an umbrella term to describe the presence of Parkinsonian symptoms. It doesn't really tell you anything about the etiology. Parkinson's disease, which you'll all know about, is idiopathic Parkinsonism, i.e. we don't know why people have it. Drug-induced Parkinsonism and vascular Parkinsonism are important, and we'll talk about them in due course. So, a bit of neuroanatomy, bear with me, please don't switch off. You'll recall that dopamine is a neurotransmitter that plugs into those receptors and helps with induction of action potentials. In Parkinson's and the substantia nigra, this goes awry, and we get loss of presynaptic neurons, and as a result, motor symptoms. So how do we differentiate between the different causes of Parkinsonism? Well, a key thing is when you take the history from the patient, this is typically a condition that comes on gradually. Secondly, a key thing when you examine the patient is that their Parkinsonian signs are unilateral, and this asymmetry remains even in advanced PD, when there's bilateral involvement, the side predominance still persists. Drug-induced Parkinsonism is represented here by these red blobs that are sitting in the receptors, blocking the action of dopamine. And top tip, someone who looks Parkinsonian, have a look at their medications. This is the Cardex of doom for someone who's got Parkinsonian symptoms. Very, very easy for patients to accumulate medications like this, particularly elderly patients, and all of these can make Parkinson's symptoms worse or give you drug-induced Parkinsonism. So top tip, have a look at the medications, including recent prescriptions. You should suspect drug-induced if they've had a history of one of these culprit drugs, and on examination you should be alerted to this if you think that they have symmetrical Parkinsonian signs. Vascular Parkinsonism is caused by disruption of the blood supply to this synapse. You see here loss of the blood supply, damage to the tissue. Clues that should alert you to vascular etiology is a gradual or stepwise deterioration that's typically caused by small vessel disease. On examination, we tend to see a symmetrical involvement of Parkinsonian signs. Classically, we often see what's termed marche à petits pas, or walking or marching with little steps. Patients with the vascular Parkinsonism often have an extremely shuffly gait, but relatively preserved arm swing. Vascular Parkinsonism can also present acutely with an acute infarct of the basal ganglia that will give asymmetrical signs on the contralateral side to the infarct. Essential tremor is one of the main differentials for Parkinson's and can be really quite tricky to discern between the two. Clues for this are that the tremor tends to be on action. There's also no bradykinesia to be found. Note, when you examine the patient, you'll often find that the signs are symmetrical and affect both sides. Key clues in the history are that this is often a family history, typically autosomal dominant, and that patients often report that alcohol will improve their tremor. Differentiating Parkinson's and essential tremor is the only circumstance where we really tend to rely heavily on imaging. The majority of diagnostics in Parkinson's disease is based on your clinical history and examination. DAT scan is the test we use for differentiating difficult cases of PD or essential tremor. What this does is it examines the dopamine transporter system that's involved with the recycling of dopamine. Here you see the dopamine spat out from the postsynaptic receptor and recycled back into the presynaptic neuron. Here an example of a nice normal DAT scan that we'd see in a normal subject or in someone with essential tremor. And you see here the light up in these basal ganglia represent normal dopamine reuptake. Compare this to a patient with Parkinson's disease. Clear difference between the two. Note also the asymmetry that you see in Parkinson's, and this is why clinically, when we examine patients, we see this side predominance. So what are my top tips for managing a patient in whom you think has Parkinson's disease? Number one, Take the time to do a full neurological examination, bearing in the distribution of the signs in mind. Don't forget to do gait, super important. Number 2, check the patient's medications. Are we giving them something that's causing this? Number 3, don't be afraid to admit that sometimes it's really difficult, and I would say the movement disorder team know full well the challenges associated with making a diagnosis, so don't be afraid to get them involved. Number 4, I'd avoid starting any drugs, can often just serve to muddy the water. Number 5, don't order a DAT scan on everyone. They're very expensive, and they're only indicated by NICE for difficult cases where we can't discern between PD and essential tremor. So in summary, hopefully now you have a feel for what Parkinsonism is. Hopefully you'll have a practical differential diagnosis for a patient in whom you find to have Parkinsonian features. And lastly, you'll have a plan for what to do when you have a patient with this problem. More reading. Parkinson UK, the charity's website, is fantastic. Really good resources for both patients and also staff. I'd strongly recommend reading the article that you see there. The URL for it is the second in the list there. It's freely open and accessible and provides a really nice overview of what to do with patients with Parkinson's in the acute setting. Thanks for taking the time to listen to this, and we hope to see you again.